Hello, we're glad you've joined us for this live webinar, Health Economic Value of Calprotectin Testing, a Gastroenterologist's Perspective. I am Judy O'Rourke of LabRoots, and I'll be moderating this session. Today's educational web seminar is presented by LabRoots, the leading scientific social networking website and provider of virtual events and webinars advancing scientific collaboration and learning. It's brought to you by Innova Diagnostics. Innova Diagnostics, part of Werfen, has been a trusted source for autoimmune disease diagnostics for over 25 years. Innova Diagnostics is redefining autoimmunity by delivering solutions which anticipate the needs of the autoimmune laboratory. They develop new biomarkers to enhance patient care and help your laboratory improve the efficiency and quality of testing. To learn more, visit www.innovadx.com. Let's get started. You can pose questions to the speaker during the presentation while they're fresh in your mind. To do so, simply type them in the Q&A box, which will open when you click the green Q&A button at the lower left of the presentation window. Questions will be answered after the presentation. To enlarge the slide window, click on the screen icon in the lower right-hand corner of the slide window. If you experience technical problems seeing or hearing the presentation, just click on the support button found at the top right of the presentation window, or report your problem by clicking on the green Q&A button at lower left. I now present today's speaker, Katie Park, MD, Assistant Professor of Pediatrics Gastroenterology at the Lucille Salter Packer Children's Hospital at the Stanford School of Medicine. Dr. Park serves as the co-director of Stanford Children's IBD Center and the medical director of the short-stay infusion unit at Stanford Children's Health. Dr. Park's scientific investigation stems from his formal training in health services and policy research with background in biostatistics, study design, database analysis, and decision science. His current NIH-funded research is to discover cost-effective ways to manage Crohn's disease and ulcerative colitis. Dr. Park will now begin his presentation.
Thank you, Judy. I appreciate the introduction, and thanks, Innova, for sponsoring me in this educational didactic session. As we had mentioned, as Judy had mentioned, the title of my talk is Health Economic Value of Calprotectin Testing, a Gastroenterologist's Perspective. So I'd like to go ahead and start by providing a broad overview of the talk. I want to talk about the clinical ambiguity that exists between the diagnosis that people are more common with, which is irritable bowel syndrome, acronyms IBS, and folks might be aware of inflammatory bowel disease, which is IBD, and the complicated interplay between symptoms and how that can complicate how we approach the initial diagnosis. I want to talk about healthcare utilization trends for both of these particular entities. I want to move on to providing a little bit of landscape in understanding what it means to enhance the value of clinical GI practice, specifically as it relates to the utility of calprotectin testing. And then I want to talk about where the field of inflammatory bowel disease is heading for non-invasive monitoring of bowel inflammation. All right, so let's talk about what this word value means. We have heard about this value-based healthcare, and this is basically a good schematic of how we should perhaps provide some visualization of thinking about quality. High-value healthcare basically means high-quality care that's evidence-based, that's intent on improving health outcomes without increasing costs. So doing more with less. The idea of the two diseases that I am always thinking about, IBD and IBS, it's important to understand that there's a lot of clinical overlay here. And when I see a patient with diarrhea, abdominal pain, and possibly weight loss, I can actually, in my mind, think that this patient has irritable bowel syndrome or inflammatory bowel disease. So there's a lot of overlay between the two diagnoses, yet these two diagnoses are very different. Inflammatory bowel disease is a chronic inflammatory process that causes visible ulcers inside your intestines and will not go away without immune modulation or some therapy targeting the inflammation. Irritable bowel syndrome, or IBS, is a functional bowel disorder. When I mean functional is that you can basically function with the disease, but it's not comfortable. Patients have abdominal pain, they may have diarrhea, they may have disordered stooling or defecation, and sometimes they may even see mucus in the stool, suggestive of some inflammation, but it's not necessarily inflammation, but rather some malabsorption because of the maldigestion that's going on within the intestine. So whenever I see a patient with these classic symptoms, I can think of irritable bowel syndrome and inflammatory bowel disease. But what is calprotectin? Calprotectin has really catapulted onto my radar in the last few years, and it has changed my practice. Calprotectin is a calcium-bound protein extruded from perturbed inflammatory cells, primarily intestinal neutrophils within the walls of the mucosa. So essentially, what that means is it could potentially be increased with neutrophils that have died and extruded their cytosolic contents into the lumen of the intestine. Calprotectin makes up 60% of the cytosolic protein within neutrophils and monocytes. So what I'm trying to get at is the fact that whenever I have a patient in my clinic, there's clinical ambiguity between the IBS and IBD, and whenever I think about inflammatory bowel disease, I may even have over-reliance or under-reliance of patient-reported symptoms. So whenever I have over-reliance on patient-reported symptoms, I may start to escalate medicines. I may start to increase healthcare utilization and healthcare services, such as emergency room visits, hospitalizations even. But whenever I have under-reliance of symptom reports, such as abdominal pain, I can potentially be misled in thinking that a patient really has something that needs supportive care rather than immune modulation. So it's a delicate balance, and there is great clinical ambiguity at the point of care. So irritable bowel syndrome, just to give you perspective, it's a very common problem. I would say up to a third of patients have some recurrent abdominal pain in the U.S., but for patients who actually meet the Rome-3, which is the diagnostic criteria that you have to meet for a formal diagnosis of irritable bowel syndrome, only about 15,000 per 100,000, but I want to make sure we understand that it's an entity, it's a clinical entity that requires a lot of healthcare utilization, is even acute care services such as emergency room visits. Over 9.6 million ED visits occur, and that's probably underestimated annually in the U.S. About 1 million or more ED visits are occurring in children less than 15 years of age. The costs are enormous, and this is actually just one type of irritable bowel syndrome. Notice the C in irritable bowel syndrome type C, and what that means is constipation. So this $11,000 represents only one type of irritable bowel syndrome. So this is in order of perhaps more for patients with diarrhea type, which can definitely be somewhat debilitating and have low quality of life. Office visits are 40% of the total cost. Inpatient care and other therapies can make up a substantial proportion of the whole. And ER visits is not dismissible here either. Focusing our attention on inflammatory bowel disease, however, the prevalence is much less. Crohn's disease and ulcerative colitis make up 28 to 43 out of 100,000, but in children, and then possibly 200 to 250 or so out of 100,000 in adults. And there is great economic burden, health economic burden for this particular disease, chronic disease. And this is where my expertise and research has been focused on. And when you think about the cost of care, it is actually even double or more than irritable bowel syndrome. It's up to $20,000 per patient, and we'll talk about that in a research article that we just published in American Journal of Gastroenterology. So moving ahead, this is the paper that we just published. It's the American Journal of Gastroenterology, which is the leading journal, leading clinical journal in my subspecialty. And what we did was looked at 11 different health care or health plans across the United States. So it's a representative of all the subgroups of patients across different geographical regions in the U.S. And we found that there is tremendous healthcare utilization for inflammatory bowel disease, namely Crohn's disease. We found that in across the board, this therapy called biological therapy has been increasing in exponential trends. About $18,000 to $19,000 will be expended annually for Crohn's disease patients who are adults, and then even above $20,000 per year for patients who are less than 18. So it's actually more costly for pediatric patients and young adults. But what I'm trying to get at with this abstract slide here is the fact that we live in the age of biologics, right there in the first sentence. The age of biologics, or the era of biologics, is upon inflammatory bowel disease care. We're talking about drugs that are infused or given as an injection. These drugs are well known to the public. They're on the commercials, and people are aware of these drugs, and they are very effective, yet very, very expensive. So here's the pie chart that basically summarizes what we found. Almost half of all IBD therapeutic, half of all costs are pretty much expended on pharmacy-related costs. And it is because of the biologicals that we are using that is so great at treating and getting patients under control with inflammatory bowel disease and improving their quality of life, yet it actually is very expensive. So judicious use of these expensive pharmaceuticals will be the hot topic looking ahead in the age of, in the era of biologics. So I wanted to step back a little bit, and as I was trying to come up with this talk, I thought about my patient who really fit this talk well. So it's a real patient. Obviously, I haven't put any real identifiers into this scenario, clinical case, but it's a 16-year-old female adolescent who reported several months of abdominal pain, diarrhea, but no real weight loss. She was a high achiever. She's a cheerleader, very smart, and overall pretty health conscious without real medical problems, except for perhaps some seasonal allergies. She didn't have any sick contacts. There weren't any travel, meaning I wasn't thinking about diseases that occur when you go abroad. There was no precipitating events. There were no precipitating events that led up to her coming into my new patient slot. Her primary care pediatrician, the primary medical doctor, PMD, did a CBC, the complete blood count, a complete metabolic count, a celiac panel, an infectious stool culture panel. Everything was negative. However, there was blood in the stool, and we saw that on the occult card blood testing in the office. And we also tested for C. diff, which, if you've heard about Clostridium difficile, it's been in the news lately. It can wreak havoc on your GI tract, especially after a course of antibiotics, and that was also negative. So the patient basically, the patient had a C. diff that was positive, and we ended up treating that C. diff with oral metronidazole, which is Flagyl, and we ended up following up at a later date, and she comes back 3 months later after the initial contact and reported ongoing abdominal pain, early satiety, occasional diarrhea, and fatigue, and she actually looked worse. However, repeat C. diff testing was negative, and the CBC was normal, the complete metabolic count was normal, but a slightly low albumin at a 3.2. But remember, albumin, which is a protein in your blood, can go down if you have increased diarrhea or if you have ongoing poor nutrition. So that's what I initially thought. Well, I performed an esophagogastroduodenoscopy, or an EGD, which is the upper endoscopy. I did a colonoscopy 2 weeks later, and essentially it was not so concerning. She had normal histopathology, and the pathologist basically said, this looks like irritable bowel syndrome. I provided reassurance. I continued to follow her. I gave education on irritable bowel syndrome management, and I told her that you should keep a trigger diary and figure out what makes the what are the things going on in your life that might make the symptoms worse. So what happened is that the patient changed providers, healthcare systems. She ended up going on a different insurance plan, and she came back to me as a second opinion about a year later, and she had the same symptoms. Repeat labs were unremarkable, but because she kept coming back to me, I performed an MR angiogram, which is a MRI study, to look at the small intestine, and I didn't see anything there either. So already you can see how the story keeps on unfolding. It just keeps on going. She is not feeling well. She keeps coming back. Doctor, what's going on? And obviously, irritable bowel syndrome is what we saw, or because of the absence of any kind of clinical signs, irritable bowel syndrome is what we are left with. And I kept saying, this is irritable bowel. Anyway, around this time is when stool calprotectin, in my mind, became kind of a good test to try. And I sent off a stool calprotectin, and it came back 98 micrograms per gram. And I reviewed the literature. And lo and behold, I found that that this particular level was actually concerning for an elevated calprotectin, not too high, but it was high enough for me to not ignore it. And the decision to proceed with the repeat endoscopy was made. But what I'm trying to say is that it's not always clear if you don't have a good marker for inflammation to go to endoscopy or not go to endoscopy, and that's an important decision. The literature says that the decision to proceed with endoscopy is not always clear, particularly when classical signs are not present, such as anemia or inflammatory blood markers, or gross hematochezia is blood in the stool. Patients often present with these nonspecific symptoms, such as mild abdominal pain, intermittent diarrhea, generalized malaise, which is fatigue. And more than half of all patients who undergo endoscopy or colonoscopy for non-gross blood and other nonspecific symptoms are diagnosed with functional conditions, particularly irritable bowel syndrome in adults and children. And yet, we have to think about carefully whether or not to undergo an invasive procedure. So the fecal calprotectin, when I reviewed the literature, was 93% sensitive to 96% sensitive for a real inflammatory bowel disease problem. And it was pretty specific at 92% for adults and 76% in children. So if you look at the calprotectin at the time of diagnosis for inflammatory bowel disease, it's actually very good. This is a study by Irritable et al. In the premier journal Gut back in 2000. So literature has been available for a long time, but it's just now becoming standard of care to think about calprotectin testing prior to the decision to go to endoscopy. So calprotectin was very effective in this study at a cutoff of 50 microgram per gram at differentiating inflammatory bowel disease. So all the levels that were high on the left column there suggested true inflammatory bowel disease or Crohn's disease. And the scatter dots that you see in the middle were patients with irritable bowel syndrome who did not have inflammatory bowel disease. And calprotectin, I just wanted to say, could be elevated by other infectious, invasive processes, such as infectious Shigella or Salmonella. It can be elevated in certain parasites that are invasive and certain cancers as well. But going back to my patient that I saw, this really was a difficult case. And I'm so glad calprotectin helped me to make this decision, because I could have kept on denying the fact that the pain was from an inflammatory process. So although initially hesitant, we repeated the endoscopy and colonoscopy, and deep down into the duodenum, or deeper down into the small intestine, I find these ulcers. And when I looked at the histopathology, it was confirmatory for duodenal Crohn's, which is really tough to diagnose sometimes. So it was the calprotectin that made me bite the bullet and say, okay, I hate to do this, but we got to repeat that endoscopy and colonoscopy. She's on a biologic called infliximab or Remicade, which is the trade name, and she's doing remarkably well. She's actually about to enter college, and she's actually thriving and really living a normal life here. If you don't know, C. diff can occur in the context of inflammatory bowel disease, and it means that it is possibly a worse type of inflammation going on inside the intestines. So this is how I think about the decision tree to undergo the colonoscopy and trying to figure out when calprotectin is helpful. So a patient comes in with suspected inflammatory bowel disease or irritable bowel syndrome. I do the screening for fecal calprotectin, and I undergo the endoscopy, or if it's very low, if the calprotectin is very low, I keep on following the patient. Obviously, the endoscopy will allow me to start therapy for inflammatory conditions such as ulcerative colitis or Crohn's disease, or If it's negative, I look at other reasons for ongoing symptoms. So I wanted to share with you very briefly a cost-effectiveness analysis looking at this particular decision tree that I just presented. So using that same clinical cascade, I populated this, this cost-effectiveness model, which looked at suspected IBD patients, so the patients that don't have the diagnosis of IBD yet, and then I did the fecal calprotectin test, and all these probabilities are in the literature. And the second decision tree over in the B column on the right was to figure out whether it was cost effective at a certain cutoff level. So when I think of a high calprotectin, is it over 50 microgram per gram, or is it over 100 microgram per gram? And does it really matter if it's 96 or 98? And how would it impact clinical decision-making and health economics? So essentially what we found is that out of 100 patients who were screened for inflammatory bowel disease versus irritable bowel syndrome in adults, calprotectin saves about $417 per patient, but delayed the diagnosis in about 2 patients out of the 32 patients with ultimately IBD. In children, fecal calprotectin saved about $300, but delayed the diagnosis a little bit more in about 5 out of the 61 pediatric patients who ultimately went on to have IBD. By simply doing endoscopy without even considering fecal calprotectin testing, it would cost an additional almost $19,000 in adults and over $6,000 in children to avoid one false negative result from fecal calprotectin testing. So the few dollar amounts needed to do the fecal calprotectin testing in a scenario where the clinician is stuck between irritable bowel syndrome or inflammatory bowel disease, it is very cost effective to do the fecal calprotectin testing. We also found that fecal calprotectin cutoff of 100 microgram per gram, sorry, that should be microgram, not milligram, versus the 50 microgram per gram. To do the 50 microgram per gram as the ideal cutoff, it would cost an additional $55 in adults and $43 in children, but it yielded 2.5 patients or 6 patients in adults and children respectively. So ultimately, at the end of the day, in our discussion, we said that if your clinical suspicion for inflammatory bowel disease is substantially high, 75% or more, then direct endoscopy would win without calprotectin screening. But for most of the patients that we see in our clinic where it's not 100% sure whether or not to proceed with endoscopy, doing the fecal calprotectin screening is highly cost effective. And it only takes a little extra cost to have the cutoff very stringent at less than, at 50 microgram per gram. So this basically changed the way I practiced. I am here today because I really think that this is a great test for my patients. Arguably, one of the most common chief complaints among my patient cohort would be abdominal pain or disordered stooling or diarrhea. And I have now kind of used that 50 microgram per gram as my cutoff, and I am actually realizing that this is something that the patients like as well, because they need that objective marker. They need to know, oh, okay, my inflammatory marker in the stool is high, so I understand why my doctor needs to do the endoscopy and colonoscopy. For inflammatory bowel disease patients who have the diagnosis, I set the benchmark at less than 150 microgram per gram. There's less evidence behind that, but evidence is emerging. I just want to say briefly that the limitations of fecal calprotectin testing is that it does take a while for the calprotectin to come back, but I know smart folks in industry, are trying to have more point-of-care testing. There's higher variability in the higher numbers of calprotectin, so basically a 500 versus a 650 might not be that different. And definitely don't use the calprotectin at the time of the clean-out for any gastroenterologist that may be on the call, on the webinar, and first morning calprotectin testing is best. So what's new on the horizon? I want to just talk briefly about the fact that more and more in the IBD literature, there's evidence to say that tighter inflammatory bowel disease control is better. What I mean by that is endoscopic healing or histologic healing, which are available only through endoscopy and colonoscopy. So when I see no evidence of inflammation on endoscopy or on the slides, that's better than only calibrating my therapeutics based on symptoms alone. So where we are in our practice is that, it would not be realistic to scope everybody with inflammatory bowel disease all the time or more frequently to get at this endoscopic healing objective, but it may be more feasible to look at the stool for biomarker testing. So mucosal healing is now synonymous with deep remission, and there's always argument about what this definition means, but we know that, again, full endoscopic evaluation showing no visible lesions is a good target to have in inflammatory bowel disease. The Europeans are ahead of the game when it comes to this. They definitely are targeting that tight control and not having any visible ulcers as the therapeutic target of choice. The reason is because right there, here in the asterisk, where we think that tighter disease control will actually future disease modify. So a patient who has good control at the mucosal level now will potentially have better disease course later on in the future. And that is particularly important for my pediatric or young adult patients who obviously have a much longer lifespan to live than a 50-year-old or a 60-year-old who would be new diagnosis at the time of at the time. So so the landscape here is changing. So when I think about complete mucosal healing, obviously I need to use more drugs such as biologics, and I just wanted to kind of step back just for 1 second and quickly talk about CRP. CRP is a C-reactive protein, and it's in the blood. It's a marker of inflammation, and what this slide is showing is that it does not correlate with whether or not you have mucosal healing. So CRP has been used in the past as standard of care for assessing whether or not a patient has endoscopic healing or clinical remission of inflammatory bowel disease, and it is certainly not reliable and does not correlate with endoscopic findings. So when a patient was clinically active with Crohn's disease, CD is Crohn's disease, 55% had CRP, basically a coin flip, less than 8 milligram per liter. So there's really no correlation very little correlation between CRP and histology, and this is a problem because this used to be, this is what a lot of clinical gastroenterologists are relying on to tailor therapies. So before I end, I want to end on 3 slides, and those 3 slides kind of represent the construct of how I monitor inflammatory bowel disease using calprotectin. Okay, so after diagnosis, I monitor calprotectin serially, longitudinally over time, because I know that calprotectin predicts endoscopic activity. So without having to scope my patients, I can actually more confidently have an assessment of what's going on at the mucosal level. So what this study showed in the Inflammatory Bowel Disease Journal in 2013 is that patients with ulcerative colitis, UC, had high calprotectin levels at the time of high endoscopic activity, and whenever the patient had no endoscopic activity correlating with mucosal healing, it also showed that the calprotectin levels were low. So it was about 90%, 90 to 92% in terms of accuracy for detecting endoscopic remission. So we were able to confidently say that calprotectin predicts endoscopic activity. The second slide of the 3 here is that calprotectin actually predicts IBD relapse. So in patients who are monitored over time with calprotectin, if the calprotectin trends are going up, I know that this correlates in a statistically significant way with patients who would ultimately relapse into disease flare. So this particular study showed that calprotectin over a 12-month span was very good at predicting relapse or disease flare. For the sake of time, I'll just go right to the 3rd slide here. The 3rd point about calprotectin monitoring after diagnosis of IBD is that calprotectin predicts drug responsiveness. So you can monitor how your patients are doing with a certain therapy based on calprotectin measurements over time. So this particular study, it's a great study to refer back to. This study used Remicade or infliximab, and there was a good statistical significance in that calprotectin levels over time decreased under 100 and many under 50 microgram per gram at 10 weeks when the patients responded to the drug infliximab. And patients who did not respond continued to have persistent elevations in calprotectin. So those are the take-home pearls for me. In summary, I have really changed my practice in terms of using calprotectin as a diagnostic marker of whether or not to do endoscopy at the time of diagnosis. And then secondly, I am using calprotectin as a monitoring biomarker for how a patient does over time. Thank you for your attention. I apologize if I went over, but I'm free for discussion afterwards and any questions you all might have.
Thank you, Dr. Park, for your presentation. A quick reminder for our audience on how to submit questions. Simply type them in the Q&A box found by clicking on the green Q&A button at the lower left of the presentation window. Dr. Park will answer as many questions as time permits. And the first question is, do you expect utilization of calprotectin to increase with the use of biologic therapies?
Oh, absolutely. So that's a great question. In fact, we have just come back from the American College of Gastroenterology conference in Hawaii. I'm glad it was there. And that was a big topic of discussion. How do we monitor disease response or non-response in a non-invasive way when the outcome measure has become endoscopic healing, but obviously you're not going to scope these patients repeatedly in the context of using very expensive drugs like biologics. And as you know, biologics are rapidly increasing around the world, especially with the advent of biosimilars in Asia and Europe, anticipated to come to the States in 2017. So absolutely, I think calprotectin is going to increase, the use of calprotectin is going to increase rapidly. There's talks about using calprotectin as a biomarker for non-IBD, but you know, things such as the surgical recovery monitoring marker, and I absolutely think it's going to increase in use.
How will calprotectin diagnosis be more useful than an ASCA diagnosis?
Oh, an ASCA, right. So that's an interesting question. So an ASCA is really an ASCA positive test is really for a prognostic indicator. So a patient who has ASCA positive antibody is someone who might have a predisposition for Crohn's disease. For example, if someone has p-ANCA positive, they have a predisposition to ulcerative colitis. If they have, say, SIBR positive or some of the other markers in the blood that would suggest a certain phenotype of Crohn's disease, such as the perianal disease or the stricturing, fistulizing type. So ASCA and Calpro are on two different levels. ASCA and ANCA, p-ANCA, those kind of markers are for prognostic indicators, so that once the diagnosis is made histopathologically, you can tailor therapy based on knowledge of what that patient will phenotypically present ongoing. And then Calpro, as I have discussed, is a marker of mucosal level inflammation and can be useful for diagnosis and monitoring.
Is calprotectin better than the traditional exam for fecal leukocytes?
Yeah, that's a great question as well. So fecal leukocytes, otherwise among the clinicians known as fecal white cells, fecal whites. We just want a fecal white, we just say. So I just want to clarify that fecal white cells are dependent on the reading of the slide. It's also limited by how the staining process is done. So it's more laborious, less standardized, and it's not quantified, meaning you can get, it's quantified in the sense that you can get, greater than 15, greater than 20, but again, someone has to read the slide. Fecal white cells can actually represent inflammation as well, but a couple of limitations other than just the preparation and reading of the slide. You have to figure out whether, a fecal white cell of +2, does that mean anything to me, and what is the cutoff? Because if I swallowed, if I had sinusitis and swallowed, mucus, my fecal white cells could be elevated. So Calpro is calprotectin is more standardized. It's easier to test and reproducible. I would think that the intervariability would be less with the calprotectin, interpatient variability, and the technician reading calpro, because it's really dependent on the machine, would be less than, say, the variability of the fecal white cells. Long-winded answer, but I hope that gets at it. But no one has really compared head-to-head. But I know for a fact that when I spoke to a different group of gastroenterologists, they had the same question, and interestingly, we came to the conclusion that calpro seemed to be much more useful.
Thank you. Is there any benefit to ordering fecal calprotectin and lactoferrin tests?
Yeah, that's a great question as well. So at my institution, we used to do both. Now we've actually just kind of gone over to fecal calprotectin for a few reasons. You can quantify fecal lactoferrin, but our institution was just reporting it as positive or negative as a binary result, so we found that less useful. We like the quantification of the fecal calprotectin, and as you know, the cutoffs were very helpful for us. I'm actually writing now a systematic review on fecal biomarkers, and looking through the literature as a whole, fecal calprotectin has much more strength of evidence in use, and randomized clinical trials are using fecal calprotectin, so I think that's what we're going to start using.
Okay. If we're going to start processing calprotectin, which cutoff would you recommend for diagnosis? How did you establish the cutoff?
Yeah, so I would highly recommend reading the paper by Van Reenen at VANRHEENAN, I believe, Van Reenen et al., and he did a systematic review meta-analysis of the various studies out there. It was written in the British Medical Journal. He's an expert in fecal calprotectin along with biomarkers, and it shows there that a cutoff of 50, less than 50 was quite diagnostic, over 90% for inflammatory bowel disease, 95%. So we have kind of used Van Reenen's paper. We also recently found a great paper by Henderson et al. In the American Journal of Gastroenterology, another systematic review and meta-analysis. And these two papers agree very much that the diagnostic cutoff is less than or equal to 50 microgram per gram, and above that should consider going on to an endoscopic evaluation. Using those two papers and the strength of evidence there, that's where we did our cost-effectiveness analysis, as I presented earlier in the journal Clinical Gastroenterology, American Journal of Gastroenterology's clinical journal, and the 50 was used as a cutoff for diagnostic purposes, and then for monitoring purposes, the debate is still in the air. Studies are ongoing, but less than or equal to 200 have been thrown around. Less than or equal to 150 has been thrown around, but most likely it's going to be somewhere in that range for monitoring IBD afterwards.
It looks like we have time for one more question, and it is, do you routinely request calprotectin testing for patients presenting with stomach issues?
Absolutely. Looking at my schedule for this afternoon and then tomorrow in urgent gastroenterology clinic, out of the 15 patients that's scheduled, I just looked at it this morning, about 7 have quote-unquote abdominal pain as their chief complaint. So whenever you have a vague complaint, such as abdominal pain, because it could be anything from inflammatory, irritable bowel, post-infectious diarrhea, many different things can cause abdominal pain. I want to know very quickly whether or not to go along that decision tree that I presented of doing an endoscopic evaluation. And if I'm going to do that, I want to know whether the pretest probability is high that I will find something. So absolutely, I will order a Calprotectin on probably all 7 of those patients.
I would like to once again thank Dr. Park for his presentation. Do you have any final comments, Dr. Park?
So I think, you know, the area of monitoring inflammatory bowel disease is rapidly evolving. We know from a clinical perspective that less than 50 is a great cutoff, but we will see many more longitudinal studies, prospective studies on what the cutoff should be for endoscopic healing and histologic absence of disease when Calprotectin is under a certain cutoff. I have a feeling it's going to be around 150.
Thank you. I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today will be addressed by the speaker via the contact information you provided at the time of registration. We would also like to thank our sponsor, Innova Diagnostics, for underwriting today's educational webcast. This webcast can be viewed on demand through May 3rd, 2016. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, bye.